The aging process can look different for each of us. For most of us, this may be a time full of fulfillment and enjoyment of life and looking back at some of the things that we achieved, spending time with family members, and a happy time in our lives. For others, this can be a time of hopelessness, despair, sickness, poverty, homelessness. Geriatrics is the assessment and treatment of disease in patients over the age of 65. For the purposes of this presentation, we'll consider a geriatric patient to be age 65 and older. Aging is a linear process that begins in our late 20s to early 30s. And this is when I say linear process, it's cumulative years of aging. So a 35-year-old ages at the same rate that an 85-year-old ages. Now, various factors can accelerate the aging process, such as genetics, pre-existing medical diseases, diet, toxins, activity, and other psychosocial factors such as homelessness, poverty, and others associated with that. Our bodies have the ability to age for up to 115 years, but ultimately what happens is we become overwhelmed by the amount of cellular death and organs begin to shut down as we're not able to regenerate cells quick enough. So in 1900, the life expectancy was 49 years old, and we fast forward that to 2022, the life expectancy has gone up to 77 years of age. The aging process can complicate the way in which we provide care to an older patient. This is mainly done through us attributing symptoms to just normal aging and failing to recognize and ultimately provide correct treatment to an older patient because we assumed that their symptoms are just related to old age. It's imperative that we are knowledgeable and skilled in caring for older patients and able to provide them with compassionate care. The care that we provide to an older patient has the ability to positively affect that person's life. The elderly population in the United States is growing and represents roughly 17.7% of our US population. After the 2020 US the population of older patients over age 65 grew 34.2%. This is largely attributed to the aging baby boomer generation born between 1946 and 1964. Older patients are also a large consumer of healthcare services. They can be responsible for 30% of outpatient services. This includes utilization of EMS and are responsible for about 30% of emergency room visits. There's a couple considerations to take from this data. The first one is that the increased usage of the healthcare system places a demand on EMS systems to be able to offer more cost effective and efficient EMS services to better serve this group of patients. We're also the only providers outside of the emergency room who are available 24/7 and are often called upon to provide education and care to geriatric patients in the field. And thus, we should be well versed in assessment and treatment of a geriatric patient. Contrary to popular belief, most geriatric patients do not live in assisted living facilities such as a nursing home. 61% of older patients live with a spouse or a relative, while 27% live alone. As age increases, the chances of living alone also increases. This increases 1% for ages 65 to 74 and 8% for patients over 85 years of age. Many factors can affect the living situation of an older patient. This includes social, economic, marital status, religious beliefs. It can also include finances under economics there. With finances, don't assume that that means that they are living comfortably, as there could be issues with family members or friends, spouses, relatives, etc. who are using that patient's income. As we grow older, every system in our body goes through changes. It's important for us to understand what these changes are and how they can affect our assessment and treatment of a geriatric patient. The respiratory changes that we undergo begin with the upper airway. As some of those muscles become weaker, this can allow the tongue to fall back into the throat more easily and become an obstruction. This also allows some of the soft tissue in the back of your oropharynx to close in on themselves more easily and become an obstruction also, or at least narrow the airway leading into the glottic opening. We also see an altered shape of facial bones and just a general shape of the face. This can make obtaining a mast seal with a BVM more difficult. And elderly patients also commonly have dentures or no teeth at all. This can contribute to a poor mast seal and can also increase the chances of an airway obstruction from dentures possibly falling back into a patient's throat. In addition to weakened upper airway muscles, this can also lead to a more likely chance of aspiration and obstruction as the patient's just not able to protect their airway as well as they once were. You also lose muscle mass with your respiratory muscles. So the muscles that we use to breathe, like our diaphragm, intercostal muscles, chest muscles, abdominal muscles, neck muscles, all of those muscles become weaker. So in turn, this really affects an elderly patient's ability to compensate by increasing volume and rate in times of distress for whatever cause. We see in older patients their respiratory rate increases, so they may breathe a little bit faster normally. We also see that their tidal volume becomes more shallow, and those are just contributing factors to weakened respiratory muscles and a chest wall that becomes more stiff. As we age, we start to lose some of that coastal cartilage that allows flexibility within our chest wall, within our thoracic cavity or thoracic cage, I should say. And that becomes stiff, and that just makes deep respirations more difficult. All of those can contribute to an elderly patient's decreased ability to respond or compensate in times of distress. Moving into the lower airway. As we age, the smooth muscle lining our bronchioles also weakens, and this can do a couple different things. It can prevent us from being able to compensate effectively for causes of respiratory distress, and it can also lead to inward collapse of the bronchioles, which can narrow the airway and produce lung sounds such as wheezing as those bronchial smooth muscles collapse on themselves due to being weaker. Elderly patients also lose some of their defense mechanisms. So we previously discussed how aspiration is more likely in an older patient. They also lose some of the cilia cells in their lungs, so the ability to move mucus up and out of the airway is decreased. And this can create a breeding ground for bacteria in the lower airway and predispose those patients to conditions such as pneumonia. There's also decreased chemoreceptor and nerve impulse sensitivity. So signals coming from the phrenic nerve to the diaphragm just aren't conducted as quickly, or the body doesn't respond as quickly as it used to due to aging. That can affect your ability to compensate. And there's also a loss of sensitivity to certain chemoreceptors such as PaO2 and carbon dioxide within the blood. The body's not able to respond as efficiently as we age to those types of acute changes. A decline in cardiac function is largely attributed to an increase in coronary artery disease and atherosclerosis as we grow older. About 60% of patients over the age of 65 are affected by this. The continued buildup of calcium and cholesterol within vessel walls as we age increases the chances that an older patient experiences some sort of acute cardiac event like an MI or an aneurysm. The heart loses its efficiency and ability to elevate cardiac output in times of increased demand. Can be attributed to the changes we can see in the left ventricle that occur as a result of normal increases in blood pressure during the aging process. This means the left ventricle becomes thicker and loses some of its elasticity as we age. The left ventricle now, in turn, has to work harder to pump blood throughout the body and meet the body's demands. We also lose peripheral elasticity by about 70% over the age of 70. This means that our blood vessels are not able to adapt to changes in blood pressure as well. And this can increase chances of some sort of orthostatic event in a patient and decrease their ability to compensate in times of distress. Stiffening of the heart valves also occurs. So, stiffening of something like the aortic valve is going to decrease the amount of blood that the left ventricle can eject with any given beat. We see changes in the sensitivity of baroreceptors and the sensitivity to certain hormones such as epinephrine and norepinephrine. As the baroreceptor loses some of its sensitivity, the signal from that receptor to our adrenal glands also becomes sluggish. So, in turn, what we see is a decreased response to epinephrine and norepinephrine that leads to an elderly patient's decreased ability to compensate for low perfusion states. There's also an increased likelihood of heart arrhythmias due to the heart's electrical conduction system becoming fibrotic with age. We see that the number of pacemaker cells as we age decreases by as much as 90% at age 75. This makes it more difficult to compensate by changing our heart rate in times of distress and also makes AFib and other aberrant conduction abnormalities more likely. Brain shrinking is a normal occurrence with age. Our brain loses about 10 to 20% of its weight by age 80. We also see a loss of neurons at about 5 to 50% throughout this process. And it should be noted that brain shrinkage does not mean that older patients have a decreased mental capacity, as the brain has a really large reserve capacity and mental abilities can remain intact well throughout one's life. A complication of brain shrinkage is that this creates a void between the brain and the dura mater and predisposes this patient to bleeding within the skull. This can also mean that symptoms take longer to appear as bleeding takes up the increased space first before we start to see neurological deficits in our patients. Decreased cerebral blood flow, largely a result of atherosclerosis, leads to a slower metabolic rate. This can present as changes on a neurological exam and cause an elderly patient to respond slower and have decreased reflexes. A decrease in reflexes by an older patient can lead to an inability to protect themselves in times of distress. As brain function declines, other systems are also infected. The ability to regulate respirations, heart rate, blood pressure, the sensations of hunger and thirst are all affected. In addition to this, changes in temperature regulation can prevent an older person from perceiving extremes in temperature, hot or cold, and responding appropriately. Our senses decline as we age. Hearing loss is 4 times more common than vision loss, and both of those are very prevalent in the older population. Other senses that are affected include a decrease in taste, tactile sensation, and a decrease in sense of body position. This can lead to an unsteady gait and an increased risk of injury from falls. The changes we see in the digestive system begin with the mastification process, as our ability to chew and swallow food is decreased. We also have decreased salivation, which reduces the initial release of digestive enzymes. The esophageal sphincter muscle also weakens with age. This can lead to increased heartburn and damage to the esophagus. This can also cause an older patient to have a decreased appetite and suffer from malnutrition. As a part of the aging process, digestive system diseases such as diverticulitis are also increased. Decreased gastric motility slows digestion and can lead to flatulence, constipation, and a bowel impaction. An older patient may have to forcefully strain to use the restroom and thus suffer from a syncopal episode secondary to a vagal stimulation. The muscles of your rectal sphincter also weaken with age, and this can contribute to incontinence. Liver function also declines from 2 main mechanisms: decreased hepatic blood flow and a decrease in production of liver enzymes. This can prevent the liver from being able to break down water soluble drugs into soluble compounds that the body can excrete. The kidneys undergo a reduction in mass throughout the aging process. This leads to a decrease in the amount of filtrate that is produced as a result of a decreased filtration surface. This decreases on average about 50% from age 20 to age 90. The kidneys become less prepared to respond to stress, fluid changes, electrolytes, and acid base balance. If we look at sodium, the kidneys are slower to respond to sodium concentrations in the blood. And as a result, we can lose excessive sodium before our kidneys begin to reabsorb it. This can lead to severe dehydration that is compounded by a decreased sense of thirst. Older patients' kidneys are also prone to overhydration and hyperkalemia. This can be caused by providers if we expose an older patient to excessive amounts of normal saline and overload the kidneys. Geriatric patients are prone to a number of different endocrine diseases. Diabetes is the most common, with Mija et al. Reporting that 26.8% of older patients over the age of 65 have diabetes in the United States. As we age, the metabolism of carbs becomes more difficult as the rates of insulin and glucagon production gradually decrease throughout the aging process. The function of the immune system also declines with age. This predisposes an older patient to complications from an infection and secondary complications from other diseases. Changes to the skin are the most noticeable sign of aging. As we get older, our skin becomes drier, thinner, less elastic, and more fragile. This can increase susceptibility to trauma and infection. The changes to an older patient's skin can allow more bleeding to occur before blood clotting. Pressure ulcers can develop when sitting on bony parts as a result of thinner skin and less adipose tissue. In addition, there's not as much blood flow to the skin in an older patient, and this inhibits the ability of the body to regenerate new cells and heal itself. Wrinkling of an older patient's skin can also inhibit an accurate skin turgor assessment. And an older patient's ability to sweat is also diminished, which impairs their ability to regulate heat. The musculoskeletal system atrophies with age. We also see a decrease in neurons and ligaments and tendons losing elasticity. Fat replaces the loss of muscle mass, and this can inhibit the body's distribution of certain drugs. Fat soluble drugs lead to greater distribution throughout the body, a lower concentration in the blood, but remain in the body for a longer period of time as a result of increased fat and decreased muscle in older patients. Some older patients may experience a stooped posture and a loss of height as a result of compression of spinal bones in the spinal column. This can create difficulty with airway maneuvers and spinal immobilization in older patients. You can see kyphosis very clearly in the image on your screen. Osteoporosis is a generalized loss of bone mass. This can occur in up to 1/3 of postmenopausal women and can predispose them to hip fractures and vertebral collapse. Cognition refers to perceiving, remembering, and thinking. And as we age, the speed at which we learn or recall words slows, but our wisdom and judgment continues to improve throughout life. Only some types of memory change. Generally, the retention of a skill remains intact, such as driving a car, reading, writing. Conscious remembering of facts and events declines with age, and our working memory also declines. Working memory is the ability to retain information and use that for a task. A good example would be remembering a phone number to either write down or type into a computer. Personality traits that are unique to each individual tend to remain intact throughout life. In 2019, depression affected 18.7% of older patients over the age of 65. Adults living with chronic illnesses and in nursing facilities are more likely to suffer from depression. Factors such as alcohol abuse, medication abuse, chronic conditions are all associated with the onset of depression. Look out for red flags of depression. This can include frequent non urgent EMS calls, as we may be an important part of an older patient's social support network. This would also include frequent ED and healthcare visits. A call where the complaint does not match the physical findings, or a patient that has poor hygiene or seems to neglect their home and its cleanliness. Ask about social support and assess for the people that this patient may have around them, as that can be a clue. We should also ask an older patient, what do they like to do for fun? Their answer may allude to the onset of depression if nothing seems enjoyable to them anymore. People over the age of 65 account for 18% of all suicides. Older patients tend to plan suicides more carefully and provide fewer warning signs. They are also more successful compared to younger age groups, 1 in 4 compared to 1 in 200. Multiple factors can lead an older patient to commit suicide. This can include the death of a spouse or relative, physical illness, isolation, depression, hopelessness, substance abuse, a significant change in role of life, such as retirement, divorce, etc. There's also data that prior to committing suicide, older patients visit their doctor before the attempt. Snyder et al. Reports that 20% saw their doctor the same day they ultimately committed suicide. With suicide, keep in mind some of the do's and don'ts. Do transport these patients. Voice your concerns. Take what the patient tells you seriously. Protect the patient from further harm. Be direct when asking about suicide and offer hope. Don't be judgmental. Do not let the attempt cloud your clinical judgment. In other words, treat the physical injury first. Never leave a suicidal patient alone, and you are not sworn to secrecy. And if a patient tells you that they want to harm or kill themselves, then you should say something. Communication is crucial for an older patient's life maintenance and personal satisfaction. It's also essential for us to be able to effectively communicate with an older patient so they can convey how they are feeling to us. Our communication sets the tone with a patient, and we should present ourselves as confident, concerned, and competent. We should also ensure that our verbal and nonverbal communication styles are congruent and that they match each other so we don't confuse the patient, as our facial expressions and our body language can help convey meaning to our words. Listening is critical with an older patient. Oftentimes, these patients may take longer to respond to a question, so we should be prepared to be patient and listen to their responses. Changes in an older patient's vision can also affect communication. Snyder et al. Reports that 15% of older patients have some form of visual impairment. There's several different techniques we can utilize to help improve communication with an older patient who has a visual impairment. The first one would be asking about glasses, and if we can locate those, assist with putting them on. This can help the patient see us clearer and thus enhance communication. For patients that have a more severe form of visual impairment, we should explain everything that we are doing. This includes explaining who the providers are in the room and also explaining the patient's surroundings as we move with the patient. When assisting in moving a patient who has a visual impairment, we should always be the one to lead them and support them from falling throughout that process. Hearing loss is the most common condition that affects communication with an older patient. There are three basic types of hearing loss. We have conductive hearing loss, which is where the sound is not conducted efficiently through the outer and middle ears. This can be caused by an ear infection, allergies, fluid in the ears, or other structural abnormalities. With conductive hearing loss, this involves a reduction in the sound level that is sent throughout the ear and oftentimes can be corrected with medication or surgery. Secondly, we have sensory neural hearing loss, which involves damage to the inner ear or nerve pathways from the inner ear to the brain. This affects a patient's understanding of speech, can be caused by disease, genetics, trauma, viruses, noise exposure, and lastly, presbycusis, which is hearing loss associated with aging. Sensorineural hearing loss is also permanent and oftentimes requires correction from hearing aids. The third type of hearing loss is central auditory processing. In this type, the processing centers in the brain are damaged. This can be caused by injury, disease, or tumors. With this type of hearing loss, patients will have difficulty with sound localization and sound discrimination. Presbycusis is hearing loss that's associated with aging. Oftentimes, we lose the ability to hear high pitched sounds first and retain the ability to hear lower pitched sounds. So, a provider with a lower voice may be able to communicate more effectively with an older patient. The reverse stethoscope technique is useful for patients who are hard of hearing and may not have access to hearing aids. This involves placing the ears of your stethoscope into the patient and speaking calmly and softly into the bell of the stethoscope. We should keep in mind that a patient with a hearing impairment may not understand and hear as well when they are sick or tired, and utilizing techniques to improve communication can help with this process. The best way to improve communication is going to be asking about hearing aids. If we can locate them, it is okay for us to assist a patient with placing their hearing aids. Other things we can do include reducing background noise. This would be creating an environment where there is less distractions and possibly a one on one with the patient. Position ourselves so that our face is well lit. Oftentimes, patients will read our lips or our facial expressions to help convey meaning to our words. So, having a well lit environment specifically on our face can help the patient understand us better. We should also speak at a natural rate, and in some cases, it is acceptable to speak slightly louder. But remember, we should never yell at an older patient. There are four basic components to a hearing aid. First, we have the power supply, which powers the entire device. There's a microphone, which collects sound energy and converts that into an electrical signal. The amplifier then increases this signal and sends it to the receiver. Think of the receiver as a mini speaker. Its job is to convert the electrical signal into sound energy. That sound energy is then supplied to the ear for processing. Hearing aids also have a custom fitted earpiece that is specific for that patient. If a patient tells us that they have hearing aids, we should attempt to locate and take them with us, as this can enhance communication not only for our care, but also the continuation of the patient's care within the hospital system. Some hearing aids may also have a directional microphone that's only able to pick up sound energy from certain directions. If this is the case, we should position ourselves in that direction so the hearing aid can enhance the signal. Likely, the patient knows this and may direct you to speak from a certain angle. Some hearing aids also have a noise cancellation feature that can limit unnecessary external noise. If this is present, turning it on can help the patient hear us more clearly, especially if they have difficulty with sound discrimination or sound localization. Hearing aids may also have a telephone switch that, when turned on, is only able to process signals coming from a phone. If that's the case, we would need to flip that switch over to M instead of T. When assisting with hearing aids, there are several considerations we should take into account. The first is to check the power supply and make sure the device has power. When inserting the device for a patient, set the volume to a mid range first. And if you're inserting it into the patient's ear and you hear a loud whistle, this could be due to the volume being turned up too loud. The hearing aid that has a red dot on it always goes in the right ear. Follow the natural shape of the patient's ear during the process, as these hearing aids are custom fitted to each ear and should go in relatively easy. Things we should never do with a patient's hearing aid. Attempt to clean wax out of the mold, as this increases the chances of damaging it. We should also avoid exposing the hearing aid to excessive heat or cold and water. Lastly, never take the hearing aid apart to try to troubleshoot it. The most common cause
speech impairment in older patients is a history of stroke. Also, keep in mind that older patients are more likely to use dentures to help them eat and speak. Without dentures, the older patient's words may sound slurred and mumbled. If assisting with dentures, just keep in mind that if they are in a soaking solution, that you wash them off with water before giving them to the patient. Aphasia can be mild to severe, and there are several different types that we should be aware of. First, we have global aphasia, which is where the patient can only produce a few words and cannot read or write. This is the most severe form of aphasia. Expressive aphasia is where the patient has severely reduced speech output and can only speak in a few words. The patient may be able to read, but writing is limited. Next, we have non-fluent aphasia, which is where the comprehension of speech is limited and the patient can read and write at around an elementary level. Wernicke's aphasia does not affect speech production. However, comprehension is affected. This patient is a patient that doesn't make sense, and when asked a question, their response is not appropriate. Atomic aphasia involves the inability to find specific words in their vocabulary. When communicating with a patient who has a speech impairment, we should ask the family or caretaker if the patient has a difficulty with listening or talking. If the issue with if the issue is with listening, we can show the patient what we want them to do. And if the issue is with talking, then utilizing simple yes or no questions may be most effective. When asking questions to a patient with a speech impairment, we should utilize focused questions and avoid open ended questions. Minimizing background noise can help us better understand the meaning of the patient's words. Make sure that you have the patient's attention before asking them a question and don't stack questions on top of one another. Ask one question, let the patient understand and respond, and then ask a follow up question. Accept all communication attempts by an older patient who has difficulty with speech. Oftentimes, if the patient feels rushed, their speech can get worse. So, being patient and being willing to accept any type of communication can help improve their speech. Keep your communication simple but adult like. We can adjust our sentence, rate, and tone to emphasize keywords. Also, we can also augment our speech with hand gestures and facial expressions to further convey meaning. The same techniques that we utilize to communicate with an aphasic patient can also be used to communicate with a patient who has dementia. The approach to the assessment of an older patient requires a holistic approach. What I mean by this is we must consider external and internal factors that influence that patient's health, such as aging and social network. There are no textbook presentations with older patients. A 43-year-old smoker with chest pain is likely experiencing a cardiac event. However, an 85-year-old patient with chest pain could be experiencing a variety of diseases that it could include a cardiac event, blood clotting abnormalities, or an aneurysm. When approaching the assessment of an older patient, it is crucial to determine the patient's baseline and compare that to our current findings. The geriatric 5 M's can help us make that determination and keep in mind some key considerations throughout the assessment. We start with mind. This involves determining if the patient's cognition is normal or impaired. Mobility is how steady is the patient's gait and balance. How well can the patient stand up and walk? Medications, we should get an accurate medication list, including non prescribed medications. How is the patient able to store those medications? Are they able to take them appropriately? Our goal here is to assess and ultimately reduce polypharmacy overdose. Multi-complexity. This alludes to assessing other factors that can influence an older patient's health, like their living conditions, how well are they able to manage various health conditions, are they able to bathe themselves, etc. Try to understand what brings this older patient joy and what their priorities are. This includes their priorities for healthcare, as these can be different when compared to a younger patient. The GEMS diamond was designed to assist providers with assessing and treating older patients. G is for geriatric and really just challenges us to recall the changes of aging and understand that because our patient is older, they present atypically. E stands for environmental assessment. This can provide clues about the patient's condition or cause of their illness. We can look at the condition of the home, its cleanliness and upkeep. Look for certain hazards, such as a hole in the ceiling or the floor, gas heaters indoors, a power strip that's overloaded. Other safety concerns are applicable here also. Pay attention to the temperature of the home. Is the AC and the heat working? And how comfortable is that patient? Are certain basic needs not accounted for, like the bed or couch where the patient spends most of their time is soaked in urine and wet? Are there any signs of substance abuse, empty alcohol bottles, evidence of the patient taking more of their medications than they should? And does the patient have access to a phone to call for help? I think that's a common reason that older patients can fall and lay on the ground for multiple hours is because they don't have readily accessible access to a phone to call for help. Having access to a phone can also mean that the patient's able to access their social network easier and can improve some of their mental well-being by being able to talk to friends and family. M stands for medical assessment and is really just a reminder that older patients suffer from a variety of medical problems and a thorough history is extremely important. Various medical problems make the assessment complex as signs and symptoms often overlap with each other. The S in the GEMS diamond stands for social assessment. This includes assessing the patient's ability to perform activities of daily living, such as eating, dressing, bathing, and using the bathroom. Is the patient able to do these functions without assistance? Are there delays in getting food and medicine to the patient? The S in the GEMS diamond stands for social assessment. This involves assessing their ability to perform activities of daily living, such as eating, dressing, bathing, and using the bathroom. Is the patient able to perform these tasks unassisted? Are there delays in getting food and medicine to the patient? Does the patient have the ability to interact with others? And do they receive regular visits from family and friends? What does their social network look like? The totality of the GEMS assessment allows us to better make appropriate patient referrals that can result in maintaining an older patient's quality of life. A good example is if we identify a social disconnect with the patient receiving food and medicine, it's likely that your service has community resources that can help close that gap. And by understanding this and recognizing this during our assessment, we can help make the appropriate referral and get the patient some of the help that they need. Next, let's move into a more systematic approach to the assessment that all begins with a scene size up. Scene safety is always number one. We should never put ourselves in a scenario that endangers ourselves or our partners, as becoming victims ourselves only requires more responders. Our environmental assessment begins with scene safety, as we're looking for some of these hazards before we enter a patient's home. Also, keep in mind that additional resources may be needed to gain entry. The patient may not be able to make it to the door. Living facilities may have an after hours number that you need to call to be let in, or a lockbox outside the building somewhere that the fire department has the code to, and maybe EMS doesn't have that code. There can be disconnects in who has access to that information. We may need to call dispatch to get the code if for some reason it's not already located in our dispatch notes. Another consideration with the scene size up is choosing the appropriate PPE. This can involve us being delayed at the door of a living facility to don our PPE. We may have to wait on a nurse or another provider to come and open the door so we can gain entry into the facility. Our main priority in an initial assessment of an older patient does not change compared to younger patients. We should identify and treat underlying life threats before performing any other type of assessment, such as a social assessment. At the end of our primary assessment, we should make a priority decision. This helps determine where and by what modality we take a patient to the hospital, whether emergency, non emergency, by air, or by ground. Our initial assessment begins with a general impression. We can pay attention to things such as: is the patient talking, moving? Are they breathing? Are they bleeding extensively? Are their clothes wet with something? And other factors may include, as we approach, are they lying in a hospital bed that could help indicate chronic illness? Are they on home oxygen? This can indicate a history of pulmonary disease. Is there an ashtray beside the patient that can indicate the use of tobacco? Gather as much scene specific information as you can on your approach to a patient during the general impression. After a general impression, our initial contact with a patient is to determine their mental status. We should work to determine a baseline mental status, as this is going to be essential as we move throughout the call. Make sure to talk to the patient first and then the caregiver to determine a baseline, as if the caregiver is able to confirm the patient's mental status, this adds reliability to your assessment. Never assume that confusion is normal. This will be a grave mistake for any patient, especially an older patient, as confusion and altered mental status can be caused by numerous different causes and is not just a normal change of aging. Should also work to determine if the cause of the altered mental status is acute or chronic. Caregivers can be crucial in establishing the onset of an altered mental status. We can use tools such as APU and Alert and Oriented times 4 to help make this decision. ANO times 4 refers to alert and oriented to person, place, time, and event. Many older patients may not know the date. So instead of asking the date, ask the patient, what time of day is it? Is it morning, noon, or night? And this is acceptable to help assess orientation. Oftentimes, our ABC assessment is being performed congruently with a mental status assessment. With multiple providers on scene, the lead provider can delegate certain tasks, and that may include one provider speaking with a caregiver to determine this patient's baseline while the lead provider continues to move throughout the primary assessment. Some considerations with an airway of an older patient. Dentures can either help or hinder the assessment. If using a BVM, dentures can help obtain a better mask seal. If intubating, remove the dentures as it's too risky to leave them in place because we could possibly fracture the teeth with inappropriate form and cause aspiration or swallowing of fragments of the dentures. The ability of an older patient to protect their airway can diminish with age or disease. A patient who's on a liquid diet is a good indicator that they are at a higher risk of aspiration due to the inability to protect their airway. And part of our airway assessment is determining patency and protection and how to proceed forward. Airway positioning can also be difficult in an older patient due to cervical spine changes. We may need to appropriately pad under the neck and back to maintain airway patency or alignment of airway axes. This also provides patient comfort. Some considerations with a breathing assessment. Chest rise may be more difficult to appreciate due to a stiffer chest wall. We may need to expose the chest to adequately assess tidal volume and respiratory rate. We can use a stethoscope to better hear and assess the movement of air throughout a patient's lungs. And keep in mind that a more involved breathing assessment is needed in a geriatric patient. When moving into a circulatory assessment, the aging heart is less responsive to stimulation of the nerves to be able to adjust the rate and strength of heart contraction. This can correlate to a weaker pulse than normal. So check both sides of the patient's pulse to confirm that the weakness is due to a weaker heart and not decreased blood flow to one extremity. Be aware that certain medications can affect the patient's heart rate and how the patient responds, compensates in distress. An example would be a dehydrated patient with a normal heart rate because a beta blocker keeps the heart rate lower. Capillary refill may also be more difficult to assess due to skin changes with aging. Use other areas such as the lips. Assessing the volume status of an older patient is also slightly different, and we may have to utilize other clues to dehydration, such as sunken eye, a history of poor urine output, a low blood pressure, or dry mucous membranes. At this point, we've likely determined whether the cause is from an injury, an illness, or both. Keep in mind that with older patients, the chances of a medical condition being the cause of an injury are greater. We should obtain as much information from the scene with the time that we have, and this is largely dependent on the patient priority that we determined in our primary assessment. When doing this assessment, we should also do an environmental assessment looking for signs of elder abuse. As we work to determine the mechanism of injury, there are a couple considerations to keep in mind. One is that falls are not simple trauma for older patients. We should assess if weakness, dizziness, or palpitations precipitated the fall. Older patients may also just say that they tripped to avoid being labeled as frail because they understand that if they are labeled as frail or prone to falls, it could mean losing some of the independence that they have left in their lives. Older patients are also at a higher risk of a motor vehicle accident due to aging, in addition to delays in the diagnosis of severe injuries. So be suspicious of single vehicle accidents and ask the patient what the last thing they remember is. This can help us appreciate if there was a loss of consciousness before the accident. The rule of symmetry is just a reminder for us to compare both sides of the body to each other. Older patients can sustain a spinal injury from a lower mechanism of injury when compared to younger patients. Padding is important as the changes that occur with aging make immobilizing an older patient's spine more difficult. We should start by patting the head and neck of our patients and be prepared to modify our immobilization to prevent motion and provide comfort. Be sure to pad bony prominences such as mid back, sternum, shoulders, sacrum, and the back of their head. Older patients' skin can become damaged quickly if left laying on a hard surface. Once we're able to clear the patient of any obvious cervical or spinal injury, we should remove them from the backboard. This is something that is likely local protocol dependent, so follow your medical director's direction on transporting older patients on a backboard. Obtaining a history on an older patient can be difficult for several reasons. They may not report significant symptoms due to fear of being labeled old or a diagnosis or treatment jeopardizing their independence. We should also not allow ourselves to fall into the misconception that aches and pains are a normal process with aging. Older patients are also more likely to report multiple chief complaints. If this occurs, we can begin by asking targeted questions towards the most life threatening symptom or complaint. If we need to ask standard screening questions for each body system, that can help us gain traction and get further into our investigation or assessment. Take a really good look at a patient's medications as the medications that they're taking, how they're taking them, the frequency, all of those factors can influence that patient's health and possibly give us clues to their current condition that the patient may not otherwise be able to tell us. Older patients are predisposed to hypothermia, so we should take steps to keep them warm during our secondary assessment and cover them after treatments. Assessing vital signs. Understand some of the normal changes with aging and how certain diseases can affect a patient's vital signs. Blood pressures tend to be higher in older patients, and a normal adult blood pressure could actually be hypotensive for an older patient. Listening to lung sounds can give us crucial information that can help us better treat a patient in our secondary assessment, whether we're going to treat the patient down a congestive heart failure protocol or a difficulty breathing from asthma, COPD, etc. protocol. Reassess older patients often because their condition can change quickly. On your screen, you can see some of the common complaints that older patients present with. We should work to identify other associated causes, such as tachycardia, pedal edema, a nocturnal cough, or a productive cough. Really trying to differentiate between COPD and CHF, as both of those conditions are treated differently in the field. Chest pain oftentimes presents atypically or not at all in an older patient. The pain can be located elsewhere and mistaken for another complaint, and as such, our threshold to perform a 12 lead should be much lower in older patients. We should also expose the chest, looking for scars, pacemakers, does the patient have an LVAD, medication patches that can indicate cardiovascular disease. Other symptoms associated with chest pain that should be a red flag for providers is if the patient reports tearing chest pain and significant blood pressure changes in both arms, as this could be an indication of an aortic aneurysm. Our approach to an abdominal pain assessment is the same as any patient. We should assess and palpate each quadrant, trying to identify organ specific symptoms. Dizziness and vertigo is also a common complaint in an older patient, and should they report this complaint, we should do a couple things. We should make sure to get accurate vital signs to rule out any major life threatening causes of dizziness, assess orthostatic hypotension, and also perform a stroke assessment. With fever, we should assess the origin, duration, and any history of recent travel for that patient. Keep in mind that the heart rate may not be elevated, and a change in mental status may be our only clue or other associated finding. Ask about immunizations such as flu or pneumonia. Determine the presence of any other diseases that increase the chances of an infection, such as diabetes or renal failure. And we should also perform a head to toe exam, really looking to identify a source of infection, such as cellulitis, a pressure ulcer, or MRSA. A complaint of generalized pain can be very difficult to localize. A good history assessment can improve this. Allow the patient to explain their pain in their own words. Older people oftentimes live with pain, however, their expression of it is often muted as they are hesitant to complain about it. Believe the patient's complaint of pain, show empathy and interest in their problem, and manage their pain accordingly. A patient with a complaint of nausea, vomiting, or diarrhea. We should work to determine if the cause is acute or chronic. If it's acute, ask about any diet changes or medication changes and even recent travel. If the patient's in a care facility, ask the caregiver if any other residents have the same symptoms, as that can indicate some sort of outbreak of a GI disease like norovirus or C. diff. If it's chronic nausea, vomiting, and diarrhea, ask about a change in pattern. Is there anything that precipitated these new symptoms or an aggravation of the chronic symptoms? Look for signs of a GI bleeding, such as bright red blood in stool or vomit, coffee ground emesis, and tar like stools. One third of hospital admissions in older adults is due to adverse drug reactions. A study done of 812 patients found that two-thirds of patients admitted to the hospital had at least one potential drug interaction in their medical history on initial presentation to the ED. There are multiple different reasons that make older patients more susceptible to drug interactions. Changes in pharmacokinetics. Pharmacokinetics is the study of the body's absorption, distribution, metabolism, and elimination of medications. Pharmacokinetics are affected by age related changes that can change how the body is able to use and eliminate a medication. Changes to absorption can affect how medication is delivered to the body. Decreases in surface area of the intestines can delay absorption, along with increased GI acidity and decreased emptying of the system. Lean body mass and body water decrease by 20% as we age. This can lead to higher drug concentrations of water soluble drugs. Body fat can also increase by about 40% during the aging process. This means that fat soluble drugs will tend to have lower blood levels, but be eliminated slower because the fat serves as a reservoir for the drugs to bind and prolong their effects. Metabolism refers to the conversion of a drug to its active metabolite. The primary site for this is the liver. So older patients that have liver dysfunction may suffer from decreased metabolism of medications. Elimination is the process of removing compounds of medications. The kidneys are the primary site for this. The liver does have some involvement with certain medications. Age-related changes to these organs have a large impact on the elimination of certain medications. Decrease in kidney function can affect diuretics and electrolyte balance. Potassium-sparing diuretics can lead to hyperkalemia, while diuretics such as HCTZ and loop diuretics can lead to hypokalemia. Declining liver blood flow also limits the ability to metabolize medications. Pharmacodynamics refers to the effect of medications on the individual. In other words, the mechanism of action of each specific medication. There are some medications, such as opioids, benzodiazepines, and warfarin, that seem to have an increased potency in older adults. Pharmacodynamics would also include how drugs interact, either a drug to drug interaction, a drug nutrient interaction, or a drug herd interaction. Older patients are also more susceptible to drug interactions due to an increased number of comorbidities, such as depression, coronary artery disease, heart failure, AFib, COPD. These all increase the risk for drug to drug interactions, largely because multiple comorbidities can mean multiple different medications to manage those conditions. A drug-to-drug interaction can occur when medications known to interact with each other are prescribed concurrently. This can occur for multiple different reasons. One being multiple physicians prescribing medications to the same patient, or a lapse in communication between healthcare systems. This could be a patient who's using multiple pharmacies or mixing a drug with an over the counter drug that their physician may not be aware of. With a drug to drug interaction, the two drugs administered together can alter the pharmacodynamics or pharmacokinetics of at least one of the medications. Drug to drug interactions are responsible for 5% of hospital admissions in patients over the age of 65. A study done in 2021 by Zira et al. Found that 80% of drug interactions were pharmacodynamic in nature, so affecting the mechanism of action of the medication and how that appears in the patient. They also found that the prescription of new medications during that patient's hospital stay was associated with increased risk of drug to drug interactions after discharge. The most prevalent classes of medications that cause a drug to drug interaction in this study included drugs that affect potassium, the heart, antithrombotic medications, and central nervous system acting drugs. This chart here illustrates the most common drug drug interactions found in Zara et al.'s study. Drug interaction 65 is prescription of more than two drugs that reduce potassium. This can include laxatives, diuretics, beta 2 agonists, and corticosteroids. 21 is the prescription of two or more drugs that spare potassium. This would include spironolactone and renin drugs such as ACE inhibitors. Drug drug interaction 12 involves anticoagulants and antiplatelet medications. Number 39 is NSAIDs and SSRIs. 36 is the prescription of more than three CNS acting drugs, such as hypnotics, antipsychotics, sedatives, antidepressants, opioids, and antiepileptics. This chart just illustrates the most common interactions that we see in prescription of medications to patients and highlights some of the things that we should look for when assessing a patient's medication history for any potential interactions or red flags. This is another chart from Zira et al. And what it illustrates for us is the most common adverse events noted upon presentation and discharge from hospital related to drug drug interactions. We can see that cardiovascular had the highest prevalence at around 20%, followed by muscular and renal involvement, bleeding issues, and neurological complaints. What's interesting about this chart is we can see how these adverse drug events increase from baseline to discharge, and then 2 months out of the hospital. This is a table from a different study conducted in 2023. The aim of this study was to assess drug combinations causing significant drug-drug interactions in patients over the age of 65. This table highlights the most common side effects they found as a result of drug interactions and is consistent with Zera et al. In the previous slides. This study also noted that the presence alone of a drug to drug interaction is 85%, and this includes significant ones in older patients. So, this means that 85% of older patients are taking medications that are known to interact with each other. This is another table from a 2023 study that highlights some of the drug interactions and the harm that they may have caused. It's important to note that some causes of drug-drug interactions may actually be intentional. Take a patient who is taking an oral anticoagulant and an antiplatelet like aspirin. This might be appropriate given a newly diagnosed AFib or patients with recent coronary syndrome or cardiac event. Mixing drugs that reduce potassium can also be clinically relevant in an acute setting for patients with heart failure if under close monitoring. Many of the drug to drug interactions noted were probably intentional or appropriate at the patient level in this study if adequate measures were being taken. As providers, there are numerous ways that we can encounter drug to drug interaction. This can be the result of decreased communication between doctors and patients, a patient not understanding how to take medications, or general non adherence to dosing schedules. All of these are things that, as providers, we should be on the lookout for, as only a thorough history and medication assessment can help mitigate this risk. It should also be noted that it is impossible for us as providers to memorize every drug drug interaction. Using third party sources on scene can help look up medication interactions if we suspect it. Many of the clinically relevant drug nutrient interactions are related to the absorption process. Grapefruit juice is known to interfere with absorption through the intestinal wall, which can lead to higher blood levels of drugs, such as calcium channel blockers, diazepam, and certain statins like lovastatin. Other examples can include certain vitamins or minerals that contain calcium, magnesium, or iron. These can affect how antibiotics are absorbed, or nutritional supplements delivered through a feeding tube can interact with drug absorption also. Vitamin K can present as a drug to nutrient interaction with a blood thinner such as warfarin. Too little vitamin K can cause an increased anticoagulant effect, whereas too much vitamin K, we see a lessened anticoagulant effect is noted. Vitamin K is also what you can find in certain blood clotting products that are available for trauma. A drug disease interaction occurs when a medication can worsen an existing disease. An example of this would be NSAIDs interfering with kidney control over a patient's blood pressure. The largest concern with this type of interaction is medications that are going to impair cognitive function and mobility. This is also going to include medications that increase the risk of fall, as that's a modifiable risk factor for older patients. So, drugs such as antidysrhythmics, diuretics, antidepressants, narcotics, and benzodiazepines are most strongly associated with an increased risk of falling. The occurrence of reported drug herb interactions appears to be rare. Regardless, providers should still assess an older patient's use of certain herbs looking for drug interactions. Echinacea is an immune stimulant that can be safe for short term usage. Some side effects of it include nausea, vomiting, diarrhea, and other GI symptoms, headache, insomnia, and an allergic reaction. This may slow down the body's ability to break down caffeine. So, when combined with some medications such as diltiazem, this can increase that drug's effect. It can also slow the metabolism of other medications. Ephedra has bronchodilator properties, can also interact with medications that cause a prolonged QT interval, such as amiodarone and certain MAOIs. Ginkgo is a memory enhancer that's contraindicated in patients using anticoagulants and NSAIDs. This combination inhibits platelet function and can increase the chance of bleeding problems. St. John's wort is the most notable drug herb interaction as it's associated with increased serotonin levels for patients taking SSRIs like sertraline. So it is contraindicated in those patients as it can lead to serotonin syndrome. When assessing for drug interactions, we should begin by gathering a thorough medication history. This includes medication names, dosages, prescribing doctor, and other information that we can find on a medication, such as the expiration date. Ask about any side effects the patient may be experiencing as a result of their medications. Assess if they're able to physically open and take their own medications. Can they manage these medications themselves, or is someone else doing it? And if so, is that person doing a good job at it? Ask about the number of pharmacies the patient uses. Have they stopped or added any new medications recently? Do they use any other drugs, such as alcohol or street drugs like cocaine, marijuana, etc.? Are they using other family members' medications to self treat themselves without a prescription? Another consideration is, are they using the right drug at the right time? Take a patient with COPD who has two types of inhalers. They have an inhaled corticosteroid inhaler and also a beta 2 agonist. But instead of using the beta 2 agonist for exacerbation, they use the corticosteroid inhaler. That could present with a drug disease interaction where the disease continues to get worse because the wrong medication is being used in acute times of distress. Also, pay attention to medication non-adherence. This is going to include the potential for abuse, either from the patient or a family member taking advantage of the patient's prescribed medications. Perform an assessment looking for adverse drug events, such as cardiovascular symptoms like orthostatic hypotension, syncope, falls, arrhythmias, central nervous system complaints such as confusion, GI symptoms, nausea, vomiting, diarrhea, abdominal pain, metabolic issues from electrolytes like potassium can contribute to cardiac effects also, and acid base imbalances. A withdrawal event can also worsen an underlying condition, such as discontinuing a diuretic for heart failure. And oftentimes, an older patient may be unaware of the risk of abruptly stopping a medication. And they may stop a medication for a minor complaint, and their disease can then continue to spiral into a more severe form. Falls are the most common cause of a traumatic brain injury in patients over the age of 65 at 46%. As a result, we should suspect a head injury with any fall that presents signs associated with a loss of consciousness, altered mental status, or signs of a direct hit to the head and neck area. Also consider some of the psychosocial effects of falling. 10% of patients aged 65 and older remain on the ground for up to 24 hours after they fall. That's a hopeless feeling to go through, and oftentimes can cause other conditions to present themselves, such as dehydration, malnutrition from laying on the floor for extended periods of time. We should also consider that a serious injury can drastically affect that patient's quality of life, and be prepared to offer support in that manner. Motor vehicle accidents, so a common cause of trauma in older patients. 17% of traffic fatalities involve older patients over the age of 65. The majority of MVCs with older patients occur during weekdays and during the day, as that's when that population is most active. In two car collisions, the car being driven by the older person is twice as likely to be the one hit. Geriatric patients have an increased severity of injury from a motor vehicle accident when compared to younger adults. Age plays a tremendous factor in this, and a dramatic increase in skeletal injuries and fractures. Musculoskeletal disorders such as arthritis and osteoporosis further increase the risk of injury due to a motor vehicle accident. The causes of a cervical and spinal injury in an older patient can be related to aging, medication use causing some sort of postural hypotension or confusion, and decreased coordination from chronic conditions. The mechanism of injury that leads to a spinal injury in older patients is often much lower when compared to a younger patients. In addition, older patients generally present with incomplete neurological deficits because of this. And the theory is that this is due to a more common lower mechanism spinal injury in older patients. There are three common types of spinal cord injuries we should be aware of. The first is central cord syndrome. This is associated with cervical hyperextension, as older patients are more prone to this due to spondylosis, which is a degenerative condition causing narrowing of the spinal canal. With hyperextension, the cord is pinched, resulting in neurological injury. These patients tend to experience disproportionate weakness in the upper extremities compared to the lower extremities, and often do not have an associated cervical fracture. The next type is cervical hyperextension. Older patients tend to have stiff necks from degenerative changes that occur to the spine and cervical spine during aging, and this can severely affect their range of motion. So be suspicious of an older patient with a hyperextension mechanism and abrasions to the head and face, such as a rear end collision or a frontal collision. And the third type is odontoid fractures. This is a fracture of C2, specifically the odontoid process, that usually occurs from falls. Majority of patients with this type of fracture do not have a neurological deficit, and that's largely attributed to just the wide stance of cervical vertebrae 2 for fracture to occur, but not cord impingement. Rib fractures are also common in older patients following blunt trauma. The presence of rib fractures is associated with increased mortality and contributes to secondary complications such as pulmonary or cardiovascular presentations. Older patients are more vulnerable to a flail chest as a result of decreased muscle mass, decreased bone density, and decreased chest wall compliance. A flail chest is almost always associated with underlying pulmonary injury. The risk of an aortic injury is also increased as older patients have a lack of reserve to compensate for serious injury to the aortic wall due to dilation, stiffness, and elevated blood pressure, all being contributing factors. We should have a high index of suspicion for any elderly patient that's been involved in a deceleration type injury. Hip fractures account for over 350,000 emergency department visits in older patients each year. They can primarily occur in women who suffer from osteopenia and osteoporosis. Due to osteoporosis, low energy twisting motions can lead to lower extremity fractures in older patients as the bones lose their mass and density. Older patients also are at a higher risk of a pelvic fracture causing bleeding that requires blood transfusions. Fracture of the head, neck, or proximal portion of the femur secondary to a mechanical fall is the most common cause of extremity injuries in older patients. Even with treatment, the recovery after a hip fracture is very difficult for older patients, physically and emotionally. 18 to 33% of patients die within the first year following their injury. So we can appreciate how an older patient knows this information and knows how detrimental a hip fracture is for their health. With lower extremity fractures, this could also be caused by stepping on the brake pedal too forcefully to avoid an accident, causing a fracture of an ankle. Upper extremity fractures are rarely life threatening, but can greatly reduce that patient's independence. We can see upper extremity fractures occur secondary to a fall as a patient tries to reach their arm and hand out to catch themselves, leading to injuries to the shoulder, arm, and wrist. The management of any trauma patient begins with appropriate triage. We often under triage older patients. With older patients, less mechanism has the potential to equal a more significant trauma. Snyder et al. Reports that in 2010, a study found that patients over the age of 80 transported to an acute care hospital had a 50% mortality compared to 8% when those patients were taken to a trauma center. The takeaway point from this data is that age alone does not make the decision to go to a trauma facility, but we should have a lower threshold for transporting patients over 65 to a trauma facility. as there's more potential for underlying unseen injuries in this patient population. Use deliberate airway management. Older patients have decreased airway reflexes that increase the risk of aspiration. Compound this with trauma, and that risk goes up even more. So be deliberate with your actions and manage the airway effectively. Also, keep in mind that managing an older patient's airway can be more difficult, secondary to some of the changes that occur with aging, such as kyphosis and limited mouth opening. And depending on your local protocol, this may require you to lower some of your induction medications to prevent hypotension in an older patient. Snyder et al. Reports that hypotension in a patient over the age of 65 is set at a systolic blood pressure of 110 millimeters of mercury. Follow your local protocols for shock management, fluid replacement, and blood products. Protect against hypothermia. This is no different for an older patient. It's just much more important as older patients are less able to protect themselves from hypothermia. As soon as an injury occurs and bleeding occurs either externally or internally, the body begins to lose heat. We must make this a priority in our care. Be prepared to get creative with spinal immobilization and use paddings and pillows and blankets to help achieve a comfortable position for the patient. In 2020, 10.8% of geriatric patients had COPD. COPD causes changes to all the airway structures, including the alveoli. The mucus glands become larger, increasing mucus production and coughing. Smooth airways narrow due to smooth muscle hypertrophy, leading to airway resistance. We see alveolar tissue that is destroyed, leading to chronic inflammation and less surface area for gas exchange. So, in older patients, be on the lookout for symptoms of a COPD exacerbation, such as progressive dyspnea, use of accessory muscles, prolonged expiration, wheezing and rhonchi, or pursed lips. Acute asthma attacks in older patients are commonly caused by an infection or medication non-adherence. The rate of asthma in older patients is as high as 8%, according to Snyder et al. Asthma is characterized by bronchospasm, edema in the lining of the bronchioles, and accumulation of airway secretions. This can be complicated by comorbidities and age-related changes in lung function. With asthma attacks, part of our history should be paying attention to time, course, and onset of those attacks. Management for asthma and COPD in the pre-hospital setting is very similar. Give the patient oxygen, inhale bronchodilators. Ipotropium is really only needed once, as research has shown us that it's not effective in multiple doses. Epinephrine 1 to 1 IM can be reserved for severe exacerbations according to local protocols. Administer steroids to help decrease inflammation, and utilize non-invasive positive pressure ventilations in the form of CPAP. This has been shown to prevent intubation. When using CPAP, you should ensure that your patient is conscious and cooperative. We all know that CPAP can be difficult for a patient to accept, and it may take some coaching. We should also make sure that our patient is not hypotensive. Snyder et al. Reports that the patient's blood pressure needs to be above 90 systolic. Other local protocols may increase that number to 100 systolic or even 110 systolic. You should immediately remove CPAP if your patient shows signs of a pneumothorax, altered mental status, or becomes hemodynamically unstable. In that case, remove the CPAP and prepare to provide BVM ventilations. Pneumonia can be caused from various different factors, viral or bacterial. Influenza is a common precipitating virus to the development of pneumonia. 90% of deaths from pneumonia occur in patients over the age of 65. The presentation of pneumonia in older patients is oftentimes more subtle compared to younger adults, and symptoms such as delirium, worsening of chronic conditions, confusion and falls may be really the only initial presenting symptoms that present to EMS providers. Other symptoms can include a cough, purulent discharge, increased respiratory rate, tachycardia, again, medication dependent, fever, but not always, crackles, or rhonchi in areas of the lungs. Severe complications from pneumonia can include sepsis, which we will discuss later in the presentation, and acute respiratory distress syndrome. Acute respiratory distress syndrome has a very high mortality in older patients at about 30 to 40%. It's caused by pulmonary inflammation, which leads to increased alveolar permeability. This can allow water, solutes, and plasma to very easily leak out of the capillary beds into the alveoli. It's characterized by an acute onset of respiratory failure that's associated with diffuse alveolar damage. ARDS patients are extremely hypoxemic. Snyder et al. Reports that sepsis is the most common cause of ARDS. There's also other causes of acute respiratory distress syndrome, such as the inhalation of harmful products or direct trauma to the head or chest that either damages lung tissues or the areas of the brain that innervate those tissues. In ARDS patients, their lungs are less compliant and thus may require ventilations with increased positive end expiratory pressure to appropriately ventilate the patient. ARDS patients may also require increased PEEP as their lungs are less compliant due to this disease process. Other respiratory conditions to take note of include a pulmonary embolism. Nursing home residents are more than twice as likely to develop a PE and account for about 13% of pulmonary embolisms that develop outside of the hospital. In pulmonary fibrosis, the lung tissue becomes thick and stiff, preventing patients from being able to properly move oxygen. Most patients diagnosed with this only live about 3 to 5 years after the diagnosis. Lung cancer is the leading cause of death among men and women each year, and about 70% of those diagnoses are patients over the age of 65. Smoking is the leading factor that causes lung cancer. Others may include the asbestos, air pollution, arsenic in drinking water throughout the patient's life. And lastly, we have tuberculosis, which in the United States is fairly limited in terms of outbreak. Tuberculosis is extremely contagious, so it has a high index to spread very easily. Decreased heart function leads to a decreased cardiac output and congestion of fluid in the lungs or the body. As the left ventricle output diminishes, the body tries to compensate by increasing heart rate and trying to pump harder. This causes hypertrophy of the left ventricle, leading to congestion of blood in the lungs. As the pressure inside the capillary blood vessels of the lungs increases, it pushes fluid, mainly water, out of the capillaries and into the alveoli, resulting in pulmonary edema. The most common complaint of pulmonary edema is shortness of breath. A good rule of thumb is that in the setting of hypertension and shortness of breath, treat that as heart failure until proven otherwise. A thorough lung sound assessment is crucial in these patients to differentiate different causes of shortness of breath from either heart failure, pulmonary edema related, or another cause of respiratory distress such as asthma, COPD, anaphylaxis, pulmonary embolism, pneumonia, etc. Other symptoms we can note in older patients with heart failure include pedal edema, orthopnea, and hypertension. It should also be noted that in severe cases of heart failure that have been persistent, patients may present with hypotension as the heart is not able to physically produce a strong enough blood pressure anymore. Pre-hospital management for a patient with pulmonary edema is aimed at reducing cardiac workload, possibly with nitroglycerin according to your protocols, and increasing oxygenation. The best way to do this in a patient suffering pulmonary edema is the use of CPAP. We should consider an acute coronary syndrome when symptoms consistent with myocardial ischemia present themselves. The two major ways we see this in the field are from angina and an acute myocardial infarction. Angina is typically brief and resolves with rest or nitroglycerin. Chest pain may be localized and vague, not your classic presentation that we see in younger adult male patients. Ask about other associated symptoms such as syncope, dizziness, nausea, vomiting, and palpitations. AMI is considered with acute damage to the heart, a rise in blood markers, and ECG changes. Older patients can tolerate ischemia better due to more developed collateral circulation that is able to shunt blood around the areas of ischemia. The pain a patient's feeling in an acute MI signifies tissue death. About 30 minutes after blood flow has been cut off, heart muscle cells begin to die. What's known as silent ischemia is known to exist at a higher rate in the older population. Between 5 to 10% of patients suffer a silent MI and present atypically without the usual symptoms of acute myocardial infarction, such as chest pain. The management of both these conditions is similar. We should be prepared to manage airway, breathing, and circulation and respond acutely if this patient decompensates. Should obtain an ECG and look for changes that indicate a myocardial infarction. We should also administer aspirin and nitro according to local protocols. When transporting a patient that we suspect has an acute MI, make sure that you transport them to an appropriate facility that has the ability to take this patient to a catheterization lab. You may also perform a thrombolytic assessment, assessing for things such as the onset, bleeding disorders, history of cancer or stroke, and any recent surgery or trauma this patient may have experienced. That can help expedite the hospital's care. There are four main types of valvular heart defects that are common in the older population. The first one is aortic stenosis. This is a result of narrowing of the aortic valve due to thickening and calcification that occurs with aging. This creates an obstruction of blood flow coming from the left ventricle. This can be caused by degenerative changes to that valve throughout the aging process as the most common cause. With this type of heart defect, the left ventricle is under more pressure, which eventually leads to heart failure. Next, we have aortic regurgitation. This is usually caused by endocarditis in older patients, and the aortic valve can acutely become incompetent, leading to a back pressure in the left ventricle, ultimately resulting in heart failure. There are cases of chronic aortic regurgitation where the patient is initially able to compensate and oftentimes can remain asymptomatic for years before developing heart failure due to aortic regurgitation. Mitral stenosis in the older population almost exclusively occurs as a result of rheumatic fever. This infection leads to inflammation to the connective tissues in the heart and leads to decreased blood flow into the left ventricle. With mitral regurgitation, this creates a backflow of blood from the left ventricle into the left atrium. This condition is frequent and occurs more often with increasing age. All of these heart defects eventually put too much strain on the left ventricle and can lead to heart failure in older patients. There are numerous conduction system abnormalities in older patients with a varying degree of severity, from symptomatic to asymptomatic, creating symptoms such as chest pain, dyspnea, syncope, dizziness, and even sudden death. The management for conduction system abnormalities in older patients is the same for any other patients. We should follow our local protocols for guidance on how to manage specific heart rhythms. Atrial fibrillation is the most common arrhythmia in older patients over the age of 65, with Snyder et al. Reporting a 5 to 10% prevalence in this age group. Atrial fibrillation has numerous causes and can be preceded by a systemic illness such as pneumonia or caused by chronic conditions such as a thyroid disease, poorly controlled COPD, kidney failure, among other causes. AFib is also a major contributor to stroke in older patients. Pre-hospital management of atrial fibrillation is aimed at controlling a rapid ventricular response. This can be accomplished through administration of a calcium channel blocker or cardioversion. As providers, we should only attempt to cardiovert AFib with RVR when absolutely necessary. The risk of a stroke secondary to cardioversion is increased the longer the patient has been in AFib. Many older patients also have pacemakers and defibrillators, and if this device stops working, the patient can experience symptoms such as syncope and not be able to function and possibly be altered mental status with decreased cardiac output. There's no need to attempt to turn off a defibrillator as the electricity that it emits into the heart is not going to affect providers, and we should never place AED pads over top of a pacemaker defibrillator. Follow your local protocols again with management of these specific devices in an emergency situation. A hypertensive emergency is characterized by a systolic blood pressure greater than 180 millimeters of mercury that is associated with other symptoms, such as a severe headache, ringing in the ears, nausea, vomiting, nosebleed, and altered mental status. Untreated high blood pressure is a contributing factor to a stroke or an aortic dissection. An aortic dissection tends to come on full force and all at once and is often described as a burning, tearing type of pain. You may also note a difference in blood pressures between each arm. In the pre-hospital environment, aggressive lowering of the blood pressure is generally not recommended, as it can end up doing more harm than good. Lowering the blood pressure too quickly can result in decreased perfusion to the brain, leading to ischemia or infarction. Oftentimes, an elevated blood pressure in an emergency situation is a compensatory mechanism by the heart to perfuse the brain. So, in most scenarios, lowering the blood pressure in the pre hospital environment is not recommended. In older patients, syncope can have a wide variety of causes, from cardiovascular to neurological causes, sensitivity to medications such as antihypertensives. Older patients are also more sensitive to dehydration. Regardless of the cause, any patient with a complaint of a syncopal episode should receive a 12 lead to rule out a cardiac event. Cardiac arrest is the number one killer of people in the United States. And as you know, the patients that we're able to get a pulse back on, the road to recovery is extremely difficult. And a very small percentage of people are able to walk out of the hospital with a good neurological outcome. For us as providers, cardiac arrest in older patients really presents a moral dilemma. We're faced with our duty as professionals to provide care with the resuscitation of an older patient who likely has a very poor prognosis. We should never withhold resuscitative efforts due to concerns of effectiveness. Age is not a determining factor for CPR effectiveness and should not be used as an independent factor of survival. The management of a cardiac arrest in an older patient is the same as any other age group, and you should follow your local protocols for specific management of cardiac arrests regarding CPR. 80% of deaths that occur secondary to a stroke are in patients over the age of 65. Ischemic strokes are most common but associated with better survival, while a hemorrhagic stroke is associated with an increased mortality and less frequency. It only accounts for about 20 to 30% of strokes. Identifying the time of symptom onset in a stroke patient is crucial, as this may affect the patient's care once they arrive at the hospital. When performing a neurological exam for a stroke, use a stroke assessment tool like Los Angeles Pre-Hospital Stroke Screen, Cincinnati Stroke Scale, or another type of assessment tool that your agency may have created. This is going to help accurately identify the presence of a stroke and increase that patient's ability to receive appropriate care at the correct facility. Management goals for stroke in the pre-hospital environment include rapid recognition, early hospital notification, and rapid transport. As previously discussed, the management of hypertension, especially in a stroke, is controversial and currently not recommended. Be sure to follow your local protocols for any further guidance on this. An altered mental status is not a normal finding, and as providers, we must initially consider any and all potential causes. Deliriums is a mnemonic that can help us remember some of the potential causes of an altered mental status. It includes drugs and toxins, emotional or psychiatric causes, hypoxia or low oxygen, infection, retention of urine or stool, seizures, undernutrition or dehydration, metabolism issues such as thyroid problems, endocrine emergencies, or renal failure, and some sort of subdural hematoma or head bleed. Two-thirds of patients living in an assisted living facility have dementia. Dementia is characterized by progressive loss of cognitive function. Alzheimer's is also a common form of dementia. Many EMS responses may be a result of a new presentation of dementia related symptoms or inability to manage behavior outbursts as dementia progresses into later stages. Delirium is an acute presentation that is oftentimes reversible. The key to differentiate between dementia and delirium is to perform a very thorough history from the patient's family and caregivers and work to identify the cause of the altered mental status. Pressure ulcers present with a large burden to the healthcare system in the United States, accounting for over 5 billion US dollars each year. Pressure ulcer can occur secondary to compromised blood flow to an area of tissue, resulting in tissue death. This often occurs in patients who are immobile or debilitated. Pressure ulcers are usually localized to bony prominences such as the sacrum, greater trochanters, ischial tuberosity, patient's heels, and scapula. 95% of ulcers occur on the lower parts of the body. In addition to pressure, friction, moisture, shearing forces also contribute to the development of a pressure ulcer. Shearing and friction forces occur if a patient slides down in bed, stretching tissue and compromising blood flow. Generally, it takes about 2 hours for tissue damage to occur and is largely dependent on time, pressure, and the patient's health status. Additionally, muscle and fat are more susceptible. The damage may not be visible at the epidermis level until later. Complications from a pressure ulcer can include bleeding, cellulitis, sepsis, bone inflammation. If bacteremia is able to develop, mortality from a pressure ulcer increases to 55%. We can see the prevalence in the United States is very high, with hospitalized patients having a prevalence of 3.5% to 29%, long-term healthcare facilities at 26%, and in home healthcare seeing a 10% to 12.9% prevalence rate. Some EMS considerations for managing pressure ulcers. Pad bony areas with blankets and pillows to prevent their development. We can also educate the patient's family members on the need to move the patient and keep them mobile, pad bony areas, and look for the symptoms of a developing ulcer. Assess the ulcer for color, temp, and drainage, really looking to see if this ulcer is infected and contributing to other systemic symptoms from sepsis. Provide the patient with pain relief. Pressure ulcers are going to hurt very severely, so do not withhold pain relief for a patient in pain. Diabetes is the most common endocrine disorder that affects patients over the age of 65, with a 25.9% prevalence rate. Complications are also higher in older adults as they're more likely to lose a limb due to diabetes and more likely to die from a hyperglycemic crisis. The prevalence of thyroid disorders is 2 times that of younger adults. With hypothyroidism, this is most commonly the result of an autoimmune inflammation of the thyroid, radioactive iodine ablation, surgery, or an iodine deficiency. Amiodarone and lithium medications are also potential causes for hypothyroidism. Generally, weight gain is a initial presenting symptom of hypothyroidism. In older patients, this is not seen as often. Severe hypothyroidism presents with a myxedema coma. This can present with an altered mental status, hypothermia, and symptoms related to slowing organ function, such as bradycardia. Hyperthyroidism is a severe disease that can lead to thyroid storm, presenting with fever, tachycardia, altered mental status, and organ failure. Gastrointestinal hemorrhage is more common in older patients due to age-related changes, increasing the chances of systemic bleeding. Other diseases and comorbidities that impact the digestive system are more likely, and older patients are more likely to be taking ulcerogenics such as NSAIDs. Upper gastrointestinal bleeding occurs when there's bleeding from the esophagus, stomach, or duodenum. 50% of older patients were taking an NSAID at the time of GI symptom presentation. 90% of upper GI bleeds are caused by a peptic ulcer disease. And the first symptoms of an upper GI bleed are often lightheadedness, postural hypotension, or syncope. Hematemesis or melena can be noted. Other risk factors that can lead to an upper GI bleed include chronic alcohol use, which leads to cirrhosis of the liver, causing esophageal varices to develop as a source of serious bleeding. Lower GI bleeding is characterized by bleeding from the colon and rectum. Diverticular disease is a common cause of lower GI bleeding, and the risk of diverticulosis increases from 5% at age 40 to over 65% by age 85. Some patients with a lower GI bleed present asymptomatically, while others can present with bright red blood coming from the rectum. Inflammatory bowel disease is another common cause of GI bleeding. This includes chronic diseases and ulcerative colitis. We should begin our assessment for a patient with suspected GI bleeding by identifying any risk factors, such as a history of GI bleeds, colon cancer, constipation, diarrhea, or other signs of bleeding, such as hematemesis, melena, black tarry stools, etc. Determine the severity of the bleeding. Minor bleeding is small amounts of blood around stool or small amounts of blood found in the toilet. Significant bleeding is characterized by passing large amounts of red or maroon colored blood in association with signs and symptoms of tachycardia and hypotension. Managing a GI bleed is dependent on if it is an upper or lower GI bleed. With upper GI bleeding, airway management is crucial and may include intubation to protect against aspiration of blood. Treat hemorrhagic shock with IV fluids, whole blood, and in accordance with your agency's local protocols. Hypothermia is a reduction in core body temp below 95 degrees Fahrenheit. Older patients' response to hypothermia diminishes with age. A drop in body temperature results in muscle shivering. Older adults have about 30% less muscle mass compared to younger adults. There's also less catecholamine secretion and less insulation from skin and fat. Diabetic patients are also 6 times more likely to suffer from hypothermia. Because of these changes, hypothermia in an older patient can occur anywhere, including indoors. Mobility issues can prevent an older patient from seeking shelter. Dementia patients may not know how to make themselves warmer when they're cold. The management for hypothermia is the same for any age group. Avoid rough handling to prevent the development of a lethal arrhythmia, and the patient is not considered dead until they are. Older patients have an increased risk of developing hyperthermia from several different causes. One is self care problems. So, the increased incidences of being frail, reduced mobility, and mental illness can make self care in hot weather difficult. Living alone can cause symptoms to oftentimes go unnoticed as there's no one there to intervene. Physical challenges would include older patients not being able to sweat as well as younger patients, which contribute to the development of hyperthermia. Physical challenges can be attributed to the inability of older patients to sweat very well and prevent them from cooling their body efficiently. Chronic conditions can make the body more susceptible to heat illness. Medications, such as a beta blocker, reduce the body's ability to respond to heat stress. Amphetamines can also raise the patient's body temperature if there is drug abuse. Opioids and sedatives reduce awareness, so the patient may just not be aware that heat stroke is developing. Heat stroke is 12 to 23 times more common in patients over the age of 65. Preventing environmental emergencies can include providing access to shelters during hot and cold seasons, well-being checks for older patients who live in our communities or who are known to live alone, and educating the public on how to avoid these types of emergencies. Time permitting during a call, it may be applicable for you to check to see if the patient has access to working heat and AC, and if not, possibly connect them to some resources that can help. Death from hypothermia and heat stroke is preventable, and EMS is in a good position to minimize these environmental emergencies. The risk of dying from a fire increases with diminishing senses and limited mobility in older patients. There's also older patients who have disorders like dementia, which can affect the recognition of a fire. Medications that cause drowsiness in an older patient or those that abuse alcohol can also prevent the recognition of a fire. Older patients also have a diminished sense of pain, which can affect or prevent timely treatment and recognition of fire. The priorities in managing an older patient who suffered burns is similar to that of young adults. Burns greater than a 10% burn surface area should be transported to a burn center. Fluid resuscitation is a critical component of burn care and should begin in the pre-hospital setting. The consensus formula, which is formally called the Parkland burn formula, is 4 milliliters per kilogram per surface area, with the first half given over 8 hours and the second half given over 16 hours. So this does require some medication math on our part as pre-hospital providers. With fluid resuscitation, over resuscitation of a burn patient can lead to complications such as compartment syndrome, pulmonary edema, congestive heart failure, respiratory distress, and increased mortality in burn patients. The older the burn patient is with decreased cardiac and kidney function will be less tolerant to fluid overload. In other words, overloading them with fluid, older patients are not able to compensate for the increase in fluid as well as a younger patient can. Utilize the same aggressive approach to inhalation injuries. Wound care is also important. Cover the wounds and the patient with a burn sheet and keep them warm to prevent hypothermia. And lastly, manage the patient's pain as you transport. Make it a part of your environmental assessment to look for fire hazards like no smoke alarms or no CO alarms and other hazards that we can identify, and do our part to educate the patient on these hazards and connect them with resources that can help.